Okay, good morning, everyone. Welcome to the Learning Health Systems in Action session. Can you hear me? Okay. My name is Laura Binder. I'm a Learning Health System Facilitator at Island Health. And I'm honored to be your moderator today because this is a topic that's near and dear to me and all the work that is being presented here as well, as it's the work I do every day as well. I'd like to start us off by just taking a moment to extend our gratitude to Elder Ruth for welcoming us to the traditional unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And before I introduce our first presenters, just a couple of housekeeping items for this session. This is going to be a very busy session. We have lots of really great work here and lots of presenters, but we're going to go quite quickly. And I did start us behind, so I apologize. So in the first hour of the session, we're going to have 3 presenters come up. They're each going to do a 10-minute presentation. And then once that's done, we're going to bring everybody back up on the stage, and we'll do a question and answer period for about 20 minutes. And then we have a 15-minute break. After the break, we're going to have another 2 presentations and another question and answer period. So I'd ask you to hold your questions to the question and answer period for the microphones, or you can use the Whova app and go ahead and answer them in there. They promised me that they're putting a Q&A button in there, like the previous sessions, but I didn't see it. So if it's not there, just use the chat feature, okay? All right, let's get started. So this morning, you're going to have an exciting opportunity to see a wide range of learning health examples and how the teams are overcoming the challenges that come with this work. Our first presenters, to kick us off, take us into the high priority area of acute care and how their hospital at home program is shifting care to the community. This team, is also presenting at their patient-oriented research and learning health system work at an international conference in Vienna next year. Please welcome patient partner Beth Burke and regional pharmacy manager at Island Health, Sean Spina.
Well, good morning, everybody. How many of you have heard of Hospital at Home? Oh, a good number. That's fantastic. So I've been involved with our Hospital at Home program since 2019, and many people ask why we came up and developed Hospital at Home. But before we get there, I do want to acknowledge, as a Métis pharmacist myself and a founding board member of the Indigenous Pharmacy Professionals of Canada, I'd want to recognize the lands that we're here on today. So what is Hospital at Home? First of all, that patient is our patient that we took a picture of and a video of during the pandemic, who is operating in our Hospital at Home program. So what is Hospital at Home? It's an internationally recognized acute model of care where patients are acutely ill and their hospital bed just happens to be in their own home. It's a voluntary process, and we actually built a patient-oriented research program that really focused on understanding what is important to patients, family caregivers, and clinicians as we put this program together. The World Hospital at Home Congress, we presented some of our work in Barcelona, Spain 2 years ago, and also we've been invited to present 4 of our pieces of work at the upcoming Congress in Vienna. Hospital at Home here in British Columbia is actually garnering international global attention. So why Hospital at Home? Our physician leads in Victoria, who came early on in 2019, were really worried about providing hospital hallway medicine as a common way of practicing in emergency rooms, not only in our province, but across the country. And so this was an alternative that has been in place in other areas of the world for literally 30 or 40 years. I'm very proud to say that our alternatives to traditional hospital care offered at home in monitored environments, it's the last time I will say that, it's also known as At Home, is our patient-oriented research program that has a huge number of people on it. It has about 17 investigators. I'm the principal investigator. The 2 most important people on our research team, no offense, Tara McMillan, my research manager over there, is Beth Burke and our other patient partner, Lisa Thompson, who are incredibly valuable to our work. It keeps us grounded in what is truly important for patients. We also have a bunch of UVic researchers, hospitalists, pharmacists, nurses, our decision support people rounding out the group. When we started this process in 2019, AKA before the pandemic was known about, we did a formal stakeholder engagement process with the incredible support of the BC Support Unit. We actually did formal stakeholder engagement to understand what this new model of care is going to be like for those who are receiving the care. And we wanted to hear from people through focus groups, surveys, etc., of what success will look like as we implement this new model of care. I'm not going to go through the results here, but it was truly incredible experience to understand that. At this point, I do want to turn over the floor to Beth Burke.
Thanks, Sean. So I have notes because otherwise I would be here till this afternoon telling you how incredible this experience has been. I've been a patient partner with Hospital at Home since the beginning. At times the involvement has been challenging, but I'm still thoroughly loving every bit of it. So currently I'm an active member of the patient-oriented research team, research side, and on the program side, participating in Healthcare Excellent Canada's recent Innovation Challenge. We won first place for staff retention and satisfaction. We're thrilled. So, before retiring, I was a nurse with over 35 years' experience in direct patient care and administrative work. During those years, I and the other healthcare providers listened to the patient, we listened to their families, and we thought we knew what they needed. In hindsight, that wasn't necessarily the case. Island Health's Hospital at Home program is committed to having actual patients taking an active role. We are not just a token presence, a name on a checkbox, or on some kind of publication. Because of this work, the organization is recognizing the importance of patient partners as active members of healthcare teams. Hospital at Home's innovative approach to patient-centered care and integrating our feedback through the program's various stages have made positive changes within Island Health. There's been a change in culture, a clearer understanding of the role and importance and expectations of the patient partner, and most importantly, improvements to the care patients receive. As with anything new, there are always challenges when you start. I'll name just a few. For the most part, those have been resolved. Patient partners are volunteers. We're given an Island Health email account and address, and it's assumed that's how we will communicate. So I was expected to log into Island Health, check my emails, and do that frequently so I would get timely emails. It didn't work. Now that my home email address is included, I get the emails right away, and my response time is much quicker. As expected, some communication difficulties are to be acknowledged. Healthcare providers often use jargon, acronyms, or medical terms that only you know. Those of us outside the organization don't have a clue what you're talking about. So what we did as patient partners was we ensured that the patient instructions were worded in ways that patients and their families would understand. Collaborating on common documents continues to be an issue. Accessing the internal SharePoint or group chat on Microsoft Teams is either impossible or very, very difficult. Yeah, you're laughing, you understand what I'm talking about. The patient partner role and involvement itself can be confusing. We discovered it was easier to include us earlier rather than having to go back afterwards, change processes and procedures. I didn't need to offer feedback on how the nurse got the medication from the hospital. I did need to comment on how the patient then got the medication and how we as patients would document once we'd taken the medication. Totally different from what healthcare providers do. So the impact for us in general is it wasn't just the patient partner role itself that was confusing. It was the importance given to that. I personally experienced differences between the research side and the program side. From the research side, I was a complete equal. Program side, I was a checkbox. Okay, got a patient partner, get back to work. Many weren't sure of my role, but I was the only non-professional and non-paid person there. I'd been colleagues with some of the other members of the teams, and yet I still wasn't an equal. At one meeting, I was trying to get a word in edgeways when all the healthcare providers were assuming they knew what the patient partner needed or the patient needed, and one of the members said, "We've got a patient partner. Let's ask her." We receive an honorarium from the research side, but not from the program side. It's not about the money, it's are we valued? That has changed. The organization is recognizing that importance and the fact that patient partners can give actual examples. You know, we didn't want the healthcare provider at home to have to go out and order pizza every night because they were expected to bring food. So I have to say that as a patient partner, we're there at the table because we're passionate about it. As equals, we really can make a difference to how patients receive care. So thank you.
Thank you, Beth. And I have about 2 minutes left here, and I'm going to quickly go through these last few slides. Patient-oriented research. I am the principal investigator for our patient-oriented research team, which is really actively doing learning health system where we're taking real data from patients. My research team calls all the patients. We get that information, and every couple of weeks we are meeting with our executive leadership team to make real changes to this brand new program so it's serving the people who we're expecting to be cared for. This here is Tara McMillan in the middle, myself and our physician lead on the one side, bringing patients together. You try to depict what this looks like for social media, right? I'm going to be very quick here. Quite often in healthcare, we spend hours and hours and years and millions designing the fancy path, and people walk a different way. We don't ask people how they're going to use the things we create. The work we have done has skyrocketed around the world. Very, very proud to say in 2022, we won the Canadian College of Health Leadership Patient Experience Award, and there's Beth in the middle holding the trophy, so it's been incredible work that we've done there as well. Also, there's been articles written, and one of those things is when you do anything in healthcare or anywhere, capturing something and putting it on a piece of paper and never telling the story to anybody doesn't do any good to anybody else out there. Tell the story, always say yes, and open the opportunity to share the experiences with others. We have multiple publications, and Beth and Lisa are on those publications as well. They're also standing on stages with me when I present on this work. They are equals in everything we do. And finally, I just want to say, this is expanding globally. Here we are around the world, around the globe. We've been all over North America talking about our homegrown learning health system, hospital at home program right here in British Columbia. It's been an incredible accomplishment, and I'm very, very proud to stand here on the stage and share the story with you all. Thank you.
Good job.
Thank you, Beth and Sean. That was wonderful, and it's wonderful to have the patient perspective on that. So for our second presentation, we're moving into the realm of long-term care and a provincial initiative that is tackling challenges across the province with their INFORM project. The long-term care quality initiative is a collaborative partnership between Michael Smith, Health Research BC, the BC Ministry of Health, come on up, the health authorities, and research and academic communities. Please welcome for the team's regional health authority representatives. We have Kirsten, Rossiter, and Matthew Fagan, who are going to do the presentation, and the rest of the team is coming up for the discussion. So come on in.
Green. All right, thank you so much, everybody. We only have a quick 10 minutes, so just a snapshot of what we'll be taking you through in our slides today. Very excited to tell you all about INFORM BC. It's one of our learning health system initiatives. Everyone here on the slide had a big role in undertaking this project. On the right, we have the 5 regional practice leads, one from each of the 5 health authorities, and then the Michael Smith Health Research BC as well, and our consultant, Dawn, who's less. A lot going on this slide, but INFORM really started from a research partnership called TREC that stands for Translating Research in Elder Care, and it's a partnership that involves a bunch of key players that really aims to produce knowledge that improves elder care in long-term care. And from TREC, they have multiple research projects focusing on knowledge translation and really creating best practices and tools that can be used in long-term care to help staff and residents. So from one of these research projects came INFORM, which stands for Improving Nursing Care Home Through Feedback on Performance Data, a little bit of a mouthful, but this essentially was a clinical trial to test a very simple change process where managers could engage their teams, teams that included both residents and family partners, to make evidence-based, meaningful changes at their sites. So from this clinical trial, we took the learnings and we implemented it throughout the 5 regional health authorities in BC. So cohort 1 involved 25 homes, and it took place in 2022 and 2023. And then we adapted. Cohort 1 took the learnings, and we took on a second cohort that involved 31 homes, again across all 5 regional health authorities, and it just wrapped up in May of this year. So the purpose of INFORM is really to support managers in long-term care, to implement and sustain positive change, but also to give them the tools to learn and to know if the changes that they're making are actually doing what they're intended to do. So we're supporting them with rigorous quality improvement methods, building diverse teams, and of course, helping them celebrate success. So again, it's an evidence-based model that assists managers and with working with data. And it uses goal setting, peer support, action planning, and coaching. And it really integrates a collaborative provincial approach focused on residents and families. So for the topic selection for the second cohort, the data that we used to drive the quality improvement projects came from the Office of the Seniors Advocate data surveys. And we aligned the topics with the long-term care quality framework, so projects fell under the scope of quality of service, quality of care, or quality of life. And the process was a lot more complex than this, but to summarize, it starts with an orientation, so the regional practice leads either go to the site in person or connect with them virtually to really go over what the project entails, the different tools and resources that they'll need, and the timeline in detail. From there, there's a goal-setting workshop, which some were in person and some were delivered virtually, which is essentially a half-day where they all come together and they really nail down their goal and make an action plan and have some steps moving forwards. And then they come back for a support workshop, and in between these milestones, the regional practice leads are working one-on-one and connecting with them probably at a bi-weekly or monthly basis. So the support workshop was a virtual workshop where they had the opportunity to collaborate with and across all the participating long-term care homes. And then lastly, there was a celebration workshop where homes got to present with a poster to anyone that wanted to attend. It was open to the public and celebrate their learnings. So I will pass it off to Matthew for some results.
Thank you, Kirsten. So what we're seeing on the screen right now is just a more granular version of the topics and the projects that were completed by the 31 participating homes. So we have things like meaningful activities, building better relationships between staff and some of the persons in care, dining experiences, and trying to include the families. One of the things that I love about this slide is this is how it ended. And because it is continuous quality improvement, leaning towards that learning health system, this isn't necessarily how it started. So you will see that some of the general themes here are feeling a bit light, and that's because we do build off of the data time and time again. When we're thinking more holistically about how did the overall results turn out, we have over 90% of our teams saying that they are going to use the learnings that were taught for future improvement projects. This is really the primary outcome because this isn't a project-based approach. We want to teach the skills and have the cyclical process time and time again. In terms of the single projects on this cohort, we do have over 60% meeting or exceeding their goals, and 40% getting near their goals or making steps towards their goals. And we know based off of the goal setting literature that this is very important to set difficult to achieve goals, but also attainable. So we're really happy with this 60% actually meeting them, showing that teams took it seriously when creating difficult to achieve goals. Lastly, we do have majority of the participants positively rating all aspects of INFORM, indicating that all of the different components of the process were well received, and that's really important to us because we want to make sure that we're best utilizing the long-term care staff's time. In terms of some key learnings that helped propel the success of INFORM, the first thing that comes to mind, particularly from the RPLs, is relationship building. This has been echoed in some of the previous talks today, but it's essential when we are trying to build learning health systems and continually improve long-term care. We also know that holistic support is integral. This means that although we have specific goals we need to implement and help implement the model of INFORM, we need to take a step back and meet the homes and meet the staff where they are and provide things like emotional support. And this was clear during the evaluation and a key piece that the long-term care staff reported back to us. Additionally, measurement was something that was very difficult, but again, is essential when we are trying to do real quality improvement and building learning health systems. Working with data will be the way that we eventually reach the full learning health system, and this is something that we need to continually push with our teams. In terms of things to consider moving forward, if there was to be another cohort, the first thing that comes to mind is equity of access. There are unique differences between the health authorities, and one of the things that was clear is that we need to consider these differences when trying to implement INFORM or other projects like this. A very easy and quick example is that it's very difficult for some regions to get in person and have that true connection just due to distances. Another thing to consider is potentially streamlining materials. So instead of having multiple workshops, perhaps having one workshop. This was essentially pilot tested at the West Coast Conference of Aging, where the RPLs created a quick workshop with streamlined materials and potentially something to consider moving forward. Additionally, topic areas and the timeline. So those don't necessarily always coincide with one another. And what I mean by that is with using the Office of the Seniors Advocate data, there was many different topics, all great topics that were related to the specific homes, but sometimes those topics were easier to achieve in 6 months versus other projects that perhaps took a bit longer. So we need to consider if the timeline is really important or the topic is really important. I see we have about a minute left here, so quickly we also need to consider what is the best way to have the number of teams selected. So right now, just based off of capacity, each region had about 7 homes, 5 to 7, I believe, and that was quite a lot, and trying to bolster our capacity for taking more teams into the future. And with that, I just want to say thank you very much for listening. The RPLs will be sort of walking around today, so if you have any other questions that can't be answered, please feel free to ask. I do want to give one shout out to Amanda Letty. She isn't able to join us today, but she is the RPL from Island Health and is an integral part of our team, and we miss her a lot today, but we'll connect soon. And with that, thank you very much for your time.
It was perfect timing. You guys can't see the timer, but oh, the water's coming up. Thank you for that, Kirsten and Matthew. Our next presenters are part of the CanSolve Chronic Kidney Disease Network, a national patient-led initiative and one of 5 chronic disease networks supported by CHR's Canadian Strategy for Patient-Oriented Research. Today's presentation will focus on the network's efforts to establish a kidney check program across Indigenous communities in multiple provinces. Behind me here, we are going to welcome from the CanSolve CKD Network, Project Manager Cynthia Macdonald. You get a wave. And on the other side of me, Melanie Tolson, Patient Partnership and Capacity Building Manager. All right, here we go.
Shall I press the other green button? Yeah? Oh, there we go. All right, BC kidney check. Don't know how loud I am right now. Okay. So this is what we'll be discussing today, and we have a lot to go through, so I'm going to kind of skip through fairly quickly, but hopefully we can touch base later in the day if people have questions, or we're happy to share resources as well. So the BC Kidney Check project is a point-of-care kidney health screening initiative that stemmed out of work done in Manitoba, and it's focusing on kidney wellness checks in rural and remote Indigenous communities. I like this slide because it's sort of a snapshot of where we are right now and what has been accomplished in the past 8+ years. We currently have 16 BC First Nations communities participating in the project and have screened just over 450 individuals. We've created a strategy for authentic community engagement that we're happy to share with others. And our colleagues in Manitoba have created a risk calculator app that's been validated and proven to work quite well within our province as well. Just some future directions. I think I'm going to skip through that right now. But why are we doing this work? Why is it important? First of all, many Indigenous peoples live in rural and remote communities in this province, and access to care can be a barrier. The prevalence of chronic kidney disease within the Indigenous peoples in Canada is 2 to 3-fold higher than other Canadian populations, and roughly 1 out of 10 Canadians has some risk for chronic kidney disease. So our project goals are threefold and growing, but within the individual level, helping to keep kidneys healthy, and this was discussed at the onset of the project. This is not looking for kidney disease, this is looking for kidney wellness. So we adapted based on our patient lead in Manitoba that this is a wellness check to prevent the delay of kidney health problems and the need for dialysis or other treatments. Within the community, this is a community-based, community-driven initiative. Self-determination is at the core of what we're trying to do. So the community really drives this project with some core basic principles. And then within the healthcare system, improving early detection rates and reducing the need for urgent and emergency dialysis. And sustainability of this program, we have about 1.5 years left of funding. So this is just a snapshot of the communities that are currently taking part in the Kidney Check project. We have all 5 health authorities represented there, and this was done by expression of interest in a very transparent process. So what do? We have a sort of core central BC Kidney Check screening team that provides training to community nurses if there's capacity there for nurses to conduct the screening. We provide community engagement, so visits from our team. We book screening visits alongside with the community health representatives, decide on a venue, and continue that process of engagement. We conduct screening clinics and report back to our provincial team and provide linkages with existing healthcare resources. this is just some of the equipment. We're using point-of-care testing equipment to bring into the communities. And we've adapted and provided a mixed model approach depending on the community's needs and resources. So we do have a mobile screening team that goes into communities. Some of the communities have nurses who are trained, who are able to conduct the screening on their own. And we also do a combination of the two, depending. So the results are provided right away, and a kidney health plan is created on the spot, and any follow-up care as necessary. So some of the benefits, the results are provided in 1 hour. We can look into kidney problems early before things progress too far and prevent that dialysis and create a personalized health plan and keep community members in community. Reduction of healthcare costs, of course, is always front of mind. So what is our secret sauce? We have partnered with Indigenous patient partners, connected with community members, both leadership and healthcare providers, to help ensure that this program is done by the community. It's a culturally safe program incorporating the OCAP principles of ownership, control, access, and possession. It's community-led, community-driven, and again, we're using the point-of-care testing equipment. So this is something we've developed, our Indigenous Initiatives team has developed, and it sort of helps guide our community engagement process. And these are the 6 R's: respect, relevance, reciprocity, relationships, reflection, and reconciliation. So the community members help guide all of the events. They help with our knowledge translation materials. They review any educational materials, counseling scripts. I'm going to skip through that. And just some of the challenges we've experienced in the implementation of this project. Obviously, BC is a vast province. We have geographical challenges of getting equipment and people to certain locations. Nurse capacity in some communities is challenging. There's a lot of other, maybe more upfront issues that the community is dealing with. Retention of nurses and staff, availability of patient partners, patient partner health risk in traveling, and the cost of the supplies and the equipment. So we're hoping to support more nurse training and retention within the community using our mixed model approach to service delivery. Our goal is to screen upwards of 1,000 individuals in this phase of the project, participate with other organizations and groups who are offering screening, such as a diabetes initiative on Vancouver Island, and plan for an evaluation of engagement in screening activities. We're also going to be following up with all the communities to have sharing circles and interviews and a celebratory feast. And I'm going to hand it off to Melanie right now.
Thanks, Cynthia. Hi, everyone. So I'll just run through this very briefly. I just wanted to touch base and kind of tie in how Kidney Check is a learning health system. And because we're sort of short on time, I'll just run through this quickly. We have heard this morning all about learning health systems, so I'm sure you're probably already conceptualizing how this fits as a learning health system. We are continuously in these cycles, these iterative cycles of reflection, refinement, implementation, and cycling through to continuously adapt and innovate the program. This program has been modified and adapted for 3 different provinces. Do I have the next slide? Next slide. Yeah, so it's adapted and in 3 different provinces in varied communities with great success through that engagement with community and with the engagement of patient partners as co-researchers in all stages, in all ways, in all capacities throughout the project. So these are just some of the ways that I've highlighted that Kidney Check has operated as a learning health system. But key, I think, to it is really the relationship building. So we know that building relationships takes time, takes trust, takes all of those factors to really build those relationships. But once we've had that opportunity to engage with community and to build those relationships, build the trust, then continuously feed back into refinements and adapting the program to suit the varied needs of varied communities, then we have great success in implementing. And how are we for time? We have 20 seconds. I just wanted to bring it back to something. Synchronistically, I came across Carrie's work regarding person-centered learning health systems. And I really wanted to highlight that I think Kidney Check fits within that sphere. In fact, even maybe expanding the concept a little bit to be a community-centered learning health system. And with that, I think I better conclude. I will just mention here one little quote, and it's from Carrie's work. In summary, improving value for patients and caregivers by capturing the things that matter most to them within their life contexts needs to be part of the continuous quality improvement cycle that lies at the heart of a learning health system. Thank you.
Okay, so we're going to bring all our presenters back up, and your teammates, and do a quick Q&A here. So there is, in our session, if you go into the session, there's a little chat feature. We don't have the nice Q&A button that the keynotes had, but you can add questions there. And we also have the 2 microphones in the room. So. Okay, so no one's at the microphone, so I get the first question. So you all talked about the value of community and patients driving initiatives. So can you comment on where you've experienced challenges and how you've navigated effective engagement of community and patient collaborators? Do you need me to say that again? Can you comment on where you've experienced challenges and how you've navigated effective engagement of community and patient collaborators? Do you guys just want to answer, or do you want to go in order?
I think, so with our experience in Kidney Check, we have to wait for community to invite us. We can't impose ourselves there. So really it's the years of relationship building even prior to the onset of this project that was key, and then having the right people attend those meetings and meeting the community where they want us to meet. Often it's starting with a meal, a feast, and just getting to know each other in a conversation. Yeah, it wasn't really a challenge, but that was just what we found works.
That's great. Yeah. Does anybody else have any comments to add?
Yeah, for us in the hospital at home program, I wouldn't say the community engagement was a challenge. The biggest strength we had is we had strong collaborations with BC Support Unit, the research, and our research team here at Island Health that actually had pre-existing connections in place that allowed us to actually have those positive experiences.
Perfect. Do you want to add? Yeah.
I think with us, with the long-term care homes, meaningful engagement and relationships is extremely important. They're very relationship-oriented people working in long-term care. So our most important part is to actually be in person as much as possible, but the challenge is, as we talked before, as Matthew brought up in the presentation, is the barriers of geography and time are 2 of the kind of most important ones I think we run into. And we just go with it as best we can, and we use Zoom sometimes, and we go in person when we can.
And I think as a patient partner, from the program or the hospital side, it was for letting staff realize who we were and our credibility to participate and offer something that they would interpret as being meaningful. Sometimes, as I said before, you think you know what a patient needs and you want to ask, but you're not really sure that you don't already know the answer.
Yeah, also add another large challenge for us was a lot of the managers that we were working with at the long-term care homes were taking this on as a project kind of at the side of their desk. So they had limited time and limited capacity to meet with us on a regular basis. So it was really highly encouraged that they had a resident and or family member on the quality improvement team and worked as a liaison with us. And that also empowered the family and residents to lead a project that was really meaningful for them. So.
Awesome. Okay, we've got a couple of questions from the app, which someone, thank you for putting in the chat that they did add the Q&A button now. So for Hospital at Home team, how is Hospital at Home reaching rural remote communities, in particular Indigenous communities? If this is happening, how successful has that been?
So I guess that's for us. With respect to the Hospital at Home rural remote, that is the untapped area, right? So when we started the program 5 years ago, there wasn't a lot of technology. The pandemic wasn't in place, and there R&D that went into the current technologies that allow us to be virtual, video conferencing and stuff weren't there. Those are now refined. The thing is we're not currently in the rural remote areas. There is discussions about how do you get medications to those places. If you're truly taking patients that are require acute hospitalization and they have an acute decompensation, how do you get them back to an acute care hospital in a timely fashion if they live on an island, for example, and there's a big winter storm happening? And so I think the key principle that our physician leads impressed on us when we started was safety first. So we're developing processes and policies and refining them to ensure, but we need to ensure that patient safety is utmost paramount.
Thanks, John. Okay, we've got a question at the microphone over there. Go ahead.
Thank you. My name is Robin McCorquodale. I'm the chair of the Windermere Care Centre Family Council, vice chair of the Regional Council, and I'm a representative on the Provincial Family Council. So regarding long-term care, I'm just curious as to whether or not there was any engagement with the family councils. We initiated it at Windermere in 2023 within a month of my first discovering there was such a thing as a family council. And I see it as truly a bright light for long-term care in making change happen.
Yeah, so part of the orientation process for us was to actually present the opportunity of INFORM to various family councils. So we have a regional family council at Fraser Health that I presented at, and then locally at the sites that were interested, we engaged with the family councils to actually select the topic and what project they were going to take on.
And one thing I would just like to add to that as well is one of the things that I found really beneficial is sharing back to the family councils. So not only, as you mentioned, Kirsten, they were involved in sort of developing some of the questions and engaged throughout the process, taking the time to really celebrate all of the great things that they contributed to was really beneficial in the North, for sure.
Thank you.
And sorry, just to add to that, so for the participating homes, each of the sites were encouraged to come up with a team. And so part of that team composition included a family member or, of course, client in care, just to capture the voices and experiences of those at the long-term care center. Yeah.
Perfect, thank you. Okay, we'll go to the microphone again. We've got Lena.
Hi, everyone. My name is Magdalena Newman. I'm a lead for the Fraser Center of the BC Support Unit and supporting patient-oriented research. I have a question, or a couple questions for the Kidney Check team. I'm curious, so you mentioned you have an Indigenous engagement strategy, and that's something that I'm very curious about in my own work. And I wonder if you could talk about how did you do your initial connection with the communities that you ended up working with? Like, what was the strategy there? What worked for you in terms of like getting invited in and making that initial connection?
Sure. We partnered with the First Nations Health Authority and had leadership help support us with the initiation of the project. We also have a very small but mighty team. So we have an Indigenous liaison manager, Catherine Turner, who was, even before the project, connecting and reaching out to all of these communities. So she's sort of the face of Kidney Check, if you will. and the point person and making those connections one-on-one with the support of First Nations Health Authority. We also had patient partners on our CanSolve team attend initial visits, but it was a lot of like phone calls and chatting and, before you actually go into community, but a whole team would go together. So we had a primary care physician from the First Nations Health Authority. We had Catherine Turner, Indigenous Liaison Manager, and often Indigenous patient partners telling their story. So when the patient partners were telling their stories, I think that is when, at those feasts or at those initial visits, that is when the sort of connection and the impact, that sort of not buy-in, but that process really began.
Yeah, thanks for sharing that. And then if I have time for another question, or?
Okay, quick one. It's like I've got questions on the app. We'll do one more microphone and then we'll go to the app.
This is a learning health system question. So, for Kidney Check, what you presented, I think, was sort of like your learning health system, learning cycle approach for the overall program, in that you're learning from each community and adapting how you deliver services. Are the individual communities also going to be adapting learning cycles at their own sites? Is that a plan, or is there any interest for that?
I think that is part of the plan. So right now, we don't collect any data from the community. The only thing we're collecting right now is aggregate data. Some of the communities are conducting their own evaluation and discussion of how this process went, what worked well, what didn't work well, what can we do in the future. Kidney Check as a program will be doing sort of two sides of the evaluation process and then adjusting as we go along. We have to capture sort of those numbers metrics, but we're also going to be working with communities to capture sort of non-Western measures of success and what is meaningful in the community for their evaluation of the program, and then adapting and moving along as we go forward. Yeah.
Thank you for sharing.
Welcome.
Okay, we've got quite a few questions. I'm going to put this to Hospital at Home and to the long-term QI team. What's the most successful example of your work at your health authority?
Well, for Hospital at Home, from my perspective, and I welcome Beth to add her perspective, there's two successful examples. One of them is that we were able to spin up this program in a matter of mere months because in response to a provincial request from the Ministry of Health, and we included patient partners from the get-go. And the other success is that we reached out to the communities to understand what the program should look like. And the only thing I'll say there is, one of the things that came out of that is our people who we reached out to said they wanted to have a virtual call bell. Something we'd never thought about as a clinician. I'm a clinical pharmacist myself, and they wanted a virtual call bell, just like when they're in the hospital, they push a button and someone would reach out to them. And we created that solely because they actually talked about wanting to go out there and they may be out gardening while they're acutely admitted to the hospital.
So many things just come to mind.
What's your favorite?
So we have to have someone who is considered an adult. So the patients that we've had have ranged from 18 years of age to 100. So imagine someone who's 100 being able to stay at home, not get confused because you've moved them into some other facility and you've made them become a patient. They're at home in their own milieu with their own family. We also heard from a First Nations person who was very apprehensive having to come into a hospital. And when was told they could stay in their own home and be treated there as they should be treated, that worked. And they wrote back and said, "Thank you. I felt respected and valued." I can't say anything more.
Perfect, thank you.
from my point of view, this is like asking me to choose my favorite child. So it's a little bit difficult, but one of the examples that I would love to share came from a long-term care home called Birchview Residence. And through their project, they actually created a process to make sure that all persons in care have a life story tree up to help provide person-centered care. And they actually took it the next step. And from this, they learned a lot about the people who they were caring for. And they actually created a greenhouse and a gardening space because they realized how many people would benefit from that. So I think that was one that stands out to me.
I can share a quick one from Fraser Health. Again, hard to choose one, but one that stands out to me was a site that created a resident food council. So from their Office of the Seniors Advocate data, they noticed that in the bottom 10 was I get my favorite foods. So they created a resident food council that meets on a monthly basis and gets to go over the menu and offer suggestions and substitutions. And they actually were able to measure how many residents are getting their favorite foods each month. So they made huge progress, and there was a lot of great feedback from both the residents and the family members that were visiting. They created a nice big food board, so lots of great stuff.
And for interior health, I think it's also building on the food because meaningful engagement activities in dining were top of the list for people that wanted improvements. And they built a team of residents, family member, staff, and the leadership. And they started making change with adding different snacks and different available things during the day for different options. And they found that they're working in silo from the foods services department. And so one of the big eye-opening things for them and us is that how do they even make change of that silo within their own facility, their own home? And so they started working with them because the food services people were also trying to make changes. And so they came together and they thought, let's work together and improve the food for the home. And so they also shared that with care homes in the other regions as well. So I think that was really important.
Yeah, and just to tie everything together, I think there were various successes, but the ability for us to work collaboratively regionally, where more than 35 long-term care homes across BC were able to come together, collaborate, share, and move progressively together. I think that was a big win for us. We had a lot of positive feedback around that because I think a lot of long-term care homes, but also regionally, we do kind of work in silos. And then, of course, reinterpreting the OSA survey from the Office of Seniors Advocate, where we captured voices across various long-term care homes and really rolling out various topic ideas that were important for each of the homes, and finding points of synergy like food, getting to know me posters where residents can share their life story with staff and vice versa, and finding different niches and avenues and strategies to really maximize the information we have to instill peer-to-peer and resident-to-resident communication was really great. Yeah.
Perfect. Oh, thank you. I'm not asking the kidney team because they've had lots of questions. I'll go to the mic with Cindy, give you guys a little break. Yeah, she might not, though.
No, I'm very aware of the time as well, so
okay.
Thank you.
Go about 2 minutes.
The question is pertaining to the sustainability of the embedded patient-oriented research component, and just looking at Sean and Beth, thinking of the resources that went in to enable patient-oriented research in hospital at home at its beginning. And now as Hospital at Home continues to expand and learn and grow, how has the journey to sustain the research component as robustly as possible, how has that been? What are the challenges?
We're too excited to give up. Different times Sean has said to us, like, team, do you want to carry on? And no one has said, we want to stop. It's a passion, not just for the patient partners, but for the staff that this might be off the side of their desk. But it's too important and too passionate.
And I'll just add to that, that builds on, the good question, Cindy, thank you. That builds on to my question earlier on, is how do we take this away from the 150 people in this room and us talking about patient-oriented research and the importance of patient input when we build these systems to actually just making it a standard way that we deliver healthcare in this province, in this country, and around the globe. It's truly about putting the patient back in patient care. And I don't know how to get it out there so that when we open a unit, we welcome patient feedback. We welcome patient partners to be part of it, which is why I asked the question earlier on. I don't know the answer to that question.
Thank you for that, Sean. I think everyone has the same question. How do we do that best? Okay, so we're right on time, down to the second here. So we are going to go to a break for this session and come back at 11:45, and we'll have 2 more presenters and another question and answer period. So thank you everyone for participating. We'll see you in 15. Thank you, thank you, thank you, thank you. You guys are like off shift now. Okay, we're gonna get started in about 15 seconds or so here. So if you can take a seat or stand, that's perfectly fine to get going with another 2 presenters. To get Clara. We have to get Clara from the people. She's coming, she's coming. That was her signal. Okay, so welcome back, everybody. The second hour or so of our presentation, we're going to have 2 more speakers and another question and answer period. So just like the first session, you can either at the question and answer period go to the microphone, or the Q&A function is working in our app right now. At least on my phone. I've heard that it depends what kind of phone you have. So feel free to use that if a question pops in your mind while you're thinking and listening here. So our next presenters are applying a learning health system approach to acute mental health units in Victoria. Their work includes facilitating patient and caregiver engagement, quality improvement and research, and the integration of lived experience into care. So here to show us what an empowered community and health system collaboration can do is Zoe Newson, Peer Support Manager for Mental Health Recovery Partners for Southern Vancouver Island, and Clara, Rubicam, Learning Health System Facilitator, also my coworker, at Island Health, and she specializes in the area of acute mental health. So please welcome them. Yeah.
Thanks, everyone. Yeah, thanks, Laura, for the introduction. You can already see our titles here, but Zoe and I work really closely together on a lot of shared initiatives in the space of acute mental health and substance use at Royal Jubilee Hospital in Victoria, BC. So we're going to share a few examples with you today of some of these projects and give you a little bit of context around some of the work we've been doing, and then really happy to answer any questions that you may have. See anything else, Zoe? Yeah. All right. Okay, so lots of different diagrams of learning health systems that have been shared already in this conference. This is the one that we use mainly because it feels, it kind of boils it down to its essence, really looking at that interaction and continuous cycle between data, evidence synthesis, and practice change. And I really like this definition of a learning health system, which kind of focuses around moving a health system from delivering care to every patient to learning from the process of delivering care to every patient. That feels like it really resonates with me and really puts my attention on the area that we're trying to be focusing on, both Zoe and I. And so, like I said, we're going to be giving 2 examples of different work that we've been doing in this learning health system work in acute mental health. And when I was thinking about Robert Reed's diagram of the engine and the drivers, I really wanted to focus on that top box, which is about the fuel and the accelerants. And 2 of those really pertain to the examples we're going to share. One of them is around staff and healthcare workforce engagement, and the other one is around patient and caregiver engagement. And so our 2 examples sort of speak to how we've harnessed or tried to harness the voices of those 2 really key interest holder groups.
Oh. Hello? There we go. Yeah, so hi, I'm Zoe. As already said, I work for a community partner agency, but I manage a contract with our local health authority, so I don't work directly for Island Health, but I'm very involved in that world. So something that came up a lot, especially when I started doing this work, is recognizing that often there's a lot of emotional labor that comes through doing this engagement. A lot of it can be reliving really traumatic experiences, either your own or that of a loved one, and that a lot of the engagement was either very tokenist or episodic in nature, and that the cost of doing this engagement was like dramatically outweighing any benefits that were coming from it. So really wanted to create a better landscape so that patient and caregivers and people with lived experience are feeling like they're at a more equitable table when those decisions are being made or future directions are looked at, and less so, this decision's been made and now we're gonna float it by you and let you know it's already happened, is really bringing people together to do that work and feel like, their input is valued at that same table. Oh, okay. Yeah, so basically, again, touching on my role, going back to Dr. Reed's presentation, it was interesting looking at the silos, and I was trying to figure out where I fit within that, and there wasn't necessarily one. So first and foremost, I'm a person with lived experience. I'm also a manager for a peer support program that runs on the hospital, and everybody working on my team has shared experiences of previous psychiatric admissions in a non-clinical capacity, which is really unique and really valuable. So in these engagements too, being able to bring in those voices and the fact that we connect with folks in hospital in a really different way than other staff or providers, based on the fact that we can probably relate to some of the experiences. So doing this work and being able to bring forward a multitude of those voices was really important, and kind of helped to improve that engagement experience. Okay, and then what came from this? An acronym, woohoo! PIPE stands for Promoting Improvements in Psych Emergency Services, and this was really the idea, again, of bringing all of those different stakeholders to the same meeting, and also recognizing that engagement costs don't just happen during a meeting, but both before and afterwards as well. So recognizing, like, how are we supporting folks before they're doing this engagement, during an engagement session, and then afterwards. Yeah, and I feel like I'll click over. Oh, look at this, it's coming up right as I am talking about the things. So we do a patient partner touch base, which again is a meeting designed just for folks to be able to debrief, share experiences outside of that PIPES meeting, and have that opportunity for one-to-one check-ins, knowing that they have a designated person that they can go to if something triggering has come up or there's a suggestion, that you feel like you have a place where you can share and do that in a meaningful way too. Over to Clara.
Yeah, and just a final point I think about the PIPES meeting is that in hearing a lot of the presentations, we were just in a storyboard session, hearing the multitude of ways in which people are engaging with people with lived and living experience. It's not as if the PIPES meeting is necessarily novel in the fact that we're trying to harness and listen to the voices of people with direct experience of mental health services. I think what is unique about it is that we try as much as possible to have equal numbers of healthcare leadership and administration, clinical and operational, as well as people with lived and living experience at the same table when we have these PIPES meetings. And we really try to make sure that the topics are at the upper end of the IAP2 spectrum for engagement, so nothing at the level of just inform, or as little as possible at the level of inform, much more on the level of really kind of consult and all the way up to empower. And so there's lots of different initiatives that have come from that maybe we can speak to a bit in the question and answer period, but I think it's a continuing evolution. We're continually getting feedback from our patient and caregiver partners about what's working for them, what we could do to make it work better. So it's by no means a final product, but really trying to embrace that humility that we talked about in the opening sessions around just continually learning and being open to feedback. The second case sort of example or case study we wanted to share was around these quality improvement huddles. So back to this idea of the fuel and accelerants, this really focused on the caregiver or the health caregiver engagement work that we were focusing on. So again, this sort of data piece that was coming in was hearing from direct care staff involved in mental health service delivery at Royal Jubilee that there was a sense of sometimes disengagement from their work, some low morale, and a feeling that maybe people would share feedback in different form, either informally or over email or staff meetings, and then struggle to see actions really take hold. And so there was sometimes a frustration. People would say, oh, I mentioned something in a staff meeting 6 months ago and I haven't seen anything really change. That's not due to the lack of commitment or care on the part of operational leadership. It's that there's no dedicated person to take it forward. and it falls off the side of someone's desk. And so what we really wanted to do was think about a low barrier way to hear from staff and clinicians in this clinical environment that didn't require a sort of extraordinary effort for people to attend. It wasn't a separate meeting or a webinar that people had to dial into. It was brought to people in their own clinical environment. They could step away briefly from their clinical work and attend these 15-minute or less quality improvement huddles. So we looked at doing that. We looked at the sort of available literature, which discusses quality improvement huddles in lots of different language: safety huddles, quality huddles, team huddles. Very different from a structured team report or STR or rounds, in that it's not talking about specific clinical information about individual patients. We framed it as bring your ideas, your worries, your concerns, your challenges, your rocks in your shoe. And we've heard all kinds of things. I think we've had over 800 ideas shared at these huddles across all of our acute mental health units. And so we hear anything from we could really be able to support patients better if we had these self-care items to deliver at the point of care, to we need a bigger garbage can for sharps, it's overflowing, these things that create sort of friction in the course of day-to-day work, that there's no logical place to park it. You don't want to write a memo or an SBAR to get that kind of thing escalated, but you just want it to be done. So after we did this sort of evidence synthesis, looked at what was out there, talked a lot to our leadership to see whether it was feasible, we decided to just start doing, not wait for perfection, but just start. So we started the huddles. We started doing them in Psych Emerge last June, and since then we started them in our young adult mental health unit, our geriatric psychiatry, our psych intensive care, our adult mental health, and our walk-in crisis center, as well as our bridging care program, which is an acute day hospital. So we've spread them across a lot of the adjacent services in acute mental health at Jubilee. And we have importantly been trying to measure them as we go. So we've always been collecting process measures, like how many huddles have we done as planned, how many people have been in attendance, how many ideas have been shared, how many ideas have been completed, how do they bucket out in terms of patient supplies versus physical environment changes, staff education, things like that. And then we were so lucky, as these things often happen, to have a wonderful pharmacy resident cross our desks, into our life it was earlier this year, and she did an evaluation of the quality improvement huddles. So she did a survey of all of our direct care team, asking them, how have quality improvement huddles made a difference for you? This is one of the quotes that came from a team member saying, feeling like there are ways to ask for change and having the support to do it is a great feeling. And then she made this amazing poster, which some of the authors of the poster are in this room, and really showed, I think, some significant results. For example, that 81% of staff agreed or strongly agreed with the statement, as a result of the quality improvement huddles, I feel more able to make improvements in how I do my job. So again, it's low barrier, it's not fancy, it's being able to sit down with the team and hear what's going well and what can be done better, and then trying to make really timely change on that. I think that's it. Yeah, that's it. Thank you.
It's up to you. Thank you for that, Zoe and Clara. Now, Dr. Sorensen, you're here, right? There she is. I was like, I hadn't seen you. So our final presentation this morning, we're moving on to staff retention and recruitment, which is a top priority in BC health systems, and all BC health authorities have been tasked with developing strategies to do exactly what this project is doing. So please welcome our next presenter, a 2023 Health Research BC Partnership Award recipient and leader in long-term care and assisted living at Fraser Health, Dr. Janice Sorensen. Green is forward, red is back. Okay, and then you're right there.
All right, thank you. All right, thank you very much for the Putting Patient First conference, for the opportunity to share our case and our experiences, our preliminary experiences with micro-research. I'd also like to acknowledge my co-panelist, Sultan, and actually some of our partners from our long-term care and assisted living research partners group. So if you want to just say a wave and hello, really grateful for them to be here today. This is such a great event for us to connect. And we'll be sharing around a project where we have of an aim in regards to improving our engagement to strengthen our health workforce within a learning health system, and then our preliminary experiences with micro-research. And you're probably thinking, what the heck is micro-research? That name hasn't even been mentioned in those prior sessions. And just to give a little bit of background within our long-term care and assisted living research partners group, it was formed in December of 2021. Quite an exceptional time with the pandemic. So we first were engaging virtually and having monthly connections, and the partners getting involved and engaged as partners in our research. And in addition to our partners group, we're very grateful to have very supportive leadership within terms of in long-term care and assisted living to have established roles such as mine, and also expanding with having a couple of research associates and research coordinators to have that ongoing staff and infrastructure for research. And through the projects that we're conducting in our research unit in partnership with our partners group, that's comprised of, at this time we have 5 long-term care or assisted living residents, 3 family partners, a volunteer, and also a staff member that are engaged in our partners group. And through our research, we also have a number of different academic partners in various different universities and colleges that we partner with our research projects. And also beyond that within different organizations in the community. And one of our initial projects was with starting on the point within research priority setting. And this is actually something, just sort of a recap from a session that was from the last Putting Patients First conference, where we were looking at our research priority setting, which we co-created with our partners. And really putting within our partners' lived and living experiences at the forefront to inform in a very pragmatic way of timely issues and topics of opportunities for research, and then us as embedded researchers having some knowledge and insights within the literature, and also being able to connect with our broader health system, leadership, staff, or care communities to work within research priority setting. But some of the challenge within this, the opportunity, we're getting so many great questions and so many great ideas to conduct of research. But some of the challenges around the infrastructures and support to conduct those research projects. And some of the projects have been funded research projects, so going through that process of writing up of a research proposal, submitting it to a granting agency, waiting maybe a few months, you might or might not get in, and time goes by. So a lot of the times our partners would say, can't we just do this now? Like, we have a really good idea. And you can maybe, if those that were at the prior session and with the regional practice leads and long-term care quality initiatives, we've got a lot going on also within quality improvement. But how could we get that spirit and that sort of the timeliness within research possible within our initiatives? And going back to the analogy from the keynote session with the stool. So with our partners group, we have quite a good representation of residents and family, and also some that have mentioned of our councils. We also have connections with our family and residents councils. But we found that within that stool, the leg for staff and leadership, it's really challenging in terms of engagement within the time and the capacity and the connection to be able to get them more actively involved within that research. So we wanted to offer, within this project of strengthening within the health system and a learning health system, recognizing that, we need to have that culture and that climate to foster and to support that opportunity to get involved with research and ongoing and shared learning. And so within the initiative, we were looking at different models and approaches to be able to engage staff and the workforce within research. And also to build of networks and collaborators to be able to have ongoing collaboration more with staff and leadership. Ultimately, the same aim as my colleagues within the Long-Term Care Quality Initiative, looking at improving the quality of work-life care and quality of life for residents, family, and staff. And then came in micro-research. And this I happened to stumble across in a webinar from some months ago that was entitled around democratizing and decolonizing research, and something with micro-research. I'm like, that sounds pretty interesting. I gotta go check that out. And so a lot within what I'm sharing here, and I have a huge amount of gratitude for colleagues in Nova Scotia, a number of them here, Nani Macdonald and Bob Bortolucci, who are supporting us with the micro-research we're about to undertake. They developed back in 2008 this approach to research. And their area within research has been within global health and global health within Africa, and recognizing that the essential importance of engaging with communities and recognizing the value within building the capacity, the skills, and the infrastructure that within those countries where they're working, that it's not that they extract or where they come in, get their data, they do their research, and they're off, but there's that building of that capacity for ongoing ability to be able to conduct research. The title micro research actually comes from the concept within the micro loans and really focused within the being able to support within community-driven, community-based research. So as I mentioned, decolonizing, democratizing research, putting skills and opportunities to be able to, for communities to be able to engage and collaborate within research. And that really that focus from a grassroots, pragmatic perspective of having improvement, having of impact. And when I was listening to this session, I'm like, this is what our partners are telling us. They've come to our partners group with ultimately the aim and desire to have an impact, to be able to have improvement within the work they're doing, and also the timeliness and the kind of the urgency within wanting to do that work. I really liked how this model was very efficient and quick within the cycles, within the supports and learning and research and conducting the research. The approach itself, and when I was reflecting on the keynote sessions and some of the presentations today around learning health systems, it really aligns and resonates within the concepts of learning health systems of being relational. So within the aspect of a quantity of connections and qualities of connections, and also within organizations, within communities, being able to develop that capacity and those skills and the ability to be able to get involved and conduct research, and also a reputational aspect. There's when I was talking with one of our directors of care that has an interest to engage, they connected the dots and they saw that beyond quality improvement, research has the opportunity to impact policy. And that's one of the lessons we'll have, research into policy and being able to also learn within knowledge mobilization and having an impact and the uptake of that research results in a timely fashion. So now that we're in the preliminary stages and we're planning and preparing for micro research, we're actually, the first session of our workshop starts tomorrow and it's going until December 6th. So it's a very exciting time for us. But some of the key points into being able to do our micro research is we need coaches and mentors. So we've got about 30 individuals that have signed up as participants, some that have the ability to be fully engaged, about 2/3, and then about 1/3 where we'd say that they're auditing of the course. So it's possible for individuals to engage at the level and the time that they're able. So some people, they have time on their lunch break, and that's great. And that happens to be the time where we set in our action-oriented teamwork sessions where the teams are working on their research proposals. And then the lectures and the content, there's an online platform with learning materials, and the sessions are recorded. So then there's that flexibility and opportunity to be able to engage with the content and learn more flexibly within one's own time. So this is really this building of that infrastructure we've been really working on within having those coaches and mentors and having that in place. And within that online platform and the workshop, it's giving those skills and tools for the groups so that they're able to come up with, and just sort of going through in terms of what's taught in the course, come up with questions. And that's one of the things I know Cynthia Macdonald has said, it's like, are we asking the right questions? So it's really putting in the hands of our communities to come up with those questions. And they decide themselves in groups of with ours, we're gonna have about 10 people in the team, and decide who's got the best question. Which question do you think is well formulated, manageable within a small micro research project that we want to work on? And teams have also quite diverse, like that the stool is such. We have our partners, some at the table here, residents, family care partners, volunteers, staff, leadership, but we've also engaged our academic friends. So we've got a lot of students, also people who are working in the health system as volunteers that are maybe future healthcare professionals. So we've got quite a diversity within skill set and capacity and abilities so that there's that opportunity to work as a team. And I really liked the first the session about, you know, I'm not the expert. We all come with skills and have something to contribute as such. And one of the lessons I think is really great that micro-research includes is a lesson on humility and a lesson on reaching out to people who have those skills that one might not have. Going through within the nuts and bolts and the basics within research and quality knowledge translation, and being able to develop and construct a research proposal. So within that 3-week period, and we've got 10 sessions, about 4 hours each, the aim is each team has come up with a really great research question and a research proposal, budget, and plan. And on their last day on December 6th, they are presenting that plan to a panel of judges, some senior researchers, some of our medical director, and getting peer feedback. We also have within the micro-research network and external peer reviewers to also to advise on the projects. This is an example from our flyer that we sent out in terms of our recruitment materials, so just very basically explaining what is micro-research, the fact of it being practical, grassroots, and our recruitment, anyone wanting to improve the quality of care and life within long-term care, staff, leaders, residents, volunteers, students, professors, people in our community. Some people reaching out saying, you know, I might be going into long-term care at some point. I'd like to help and I'd like to get involved. We're conducting it in a hybrid format. Some of our partners, some of our participants really appreciate the flexibility within online, but some also like that in-person connection. So we also have that available too. And it's just coming up very soon here. Oh, I'm a couple minutes over here. We are just in the very beginning part there and have had tremendous learning. And the blue part, it's not just the workshop. We're going to be continuing and we're going to be conducting. Hopefully, you know, we got some 3 good proposals there and conducting within 2025. And just to round off, just kind of a overview within the model that I just presented there. So since this is happening now, if anyone is interested in this model, please reach out, ask questions. I've actually had people that have anything to do with long-term care and assisted living that just want to audit the course and just check it out and see what it's about and learn more about the model. So please be in touch. And any funders out there, where we got our funders? We got some funding? Anyone? Please be in touch, because we've actually invited our colleagues in the Ministry of Health, funders, members of the public to come on our last day on December 6th to see the great work that we're doing and to learn more about micro-research. So apologies to go a little bit over time, but thank you very much for your attention.
Thank you for that. We let her have a couple extra minutes. Yeah, if anyone wants to come up, please come up. Yeah, we've got enough.
Anyone else that wants to come up, you're welcome. No, you're good.
It's a friendly stage, I promise. Okay, so we have another question and answer period. So if you want to ask a question, we have another one. Yeah. They're coming. It takes the first follower. That's what they say, right? Here, go ahead. Here you go. So you can use I want to call it WUVA, it's WUVA, but WOVA in my head, app. The question and answer period is working on some people's and not, but I can ask the first question if no one has one. Okay, so to kick us off, can you comment on what measures you have in place or you'd like to have in place to ensure a healthy dose of sustainability and learning health system initiatives? Does that mean anything? How do we have a healthy dose of sustainability when we start initiatives? Yeah. Does that make sense?
So the question was about what certain key elements in terms of to ensure sustainability?
Yeah. Not enough to stop us from doing a pilot, but enough to make sure that when we're successful that we can sustain it.
So, and I think I mentioned it just very briefly in the beginning part of my presentation, we're very grateful and very fortunate to have support within leadership. So I think within having key individuals that can sponsor within the work that one's doing, and also within that broad collaboration, like that analogy within that stool, if you're thinking of the different legs within that stool to be able to support the initiative to be successful, I think that's really important for sustainability.
Do you guys want to add to that or no? Do you have a comment?
I don't have anything to add, but maybe Clara does.
Come on, Clara.
Well, I think some of what Zoe was touching on in terms of continually refining our process with regards to patient and caregiver engagement with the PIPES meeting, I think it really speaks to that sustainability part, that we don't take it for granted that we will have willing people who want to show up in the middle of the day on our schedules as health authority representatives to share intimate details of their lives, of the lives of their loved ones, undertake that emotional labor. I think not taking that for granted is the first step for sustainability, and then really approaching it as a continuous exercise in quality improvement to make sure that that experience is as good as it possibly can be, that the benefits are outweighing the costs whenever possible. I think with regards to the huddles, I think what we've seen is that having a person whose role is dedicated to quality improvement, which is myself, instead of relying on busy clinical leaders, operational leaders like the manager, the coordinator, the director, the clinical nurse educator, all of whom have myriad other responsibilities to staff and care for patients on the unit. So having a dedicated person for quality improvement is, I think, one of the steps required for sustained quality improvement huddles in those units. Somebody to run them, to take notes, to circulate the action items afterwards, to be the squeaky wheel if that's required. Because expecting busy clinical teams to do that themselves, I think, is not realistic.
Yeah, I agree. Okay, Sean.
Thank you very much for your great presentations, truly inspiring. My question is for the MHSU team there with PIPES. You've done an incredible amount of work there where you have worked in an area with low staff morale, a lot of staff turnover, and you've made a difference. You've made change happen that is impactful for the patients you serve as well as the clinicians and the staff who are working in those environments. My question is how are you going to think bigger than your local hospital? How are you going to think bigger than your health authority? And what are you going to do with the results to affect change on a bigger scale?
It's a good question, Sean.
What a great question. Yeah, it's a big question for sure. For myself, I mean, I feel like this is obvious. I really value incorporating people with lived experience. First and foremost, that's how I show up for work. That's at the core of all of my work. I really think peer support is something that's really underutilized in a lot of different areas. So the transitional discharge model, we're not just supporting folks in hospital, we're extending the option for them to continue to stay connected to someone from the peer support team after discharge. So we're helping that transition back into community and helping to kind of offset that revolving door syndrome that comes up so frequently. But also the great work that community partners do, and I think that's something that's also underutilized and underfunded, speaking of funding. But community partners can do a lot of great work. There's a lot of folks that come to places like PsychEmerge because they don't have anywhere else to go. So I think amplifying the things in community that are working and that, you know, somebody threw us some more money, we'd be able to do a whole lot of things that would be able to expand those improvements elsewhere. And ultimately, I think the goal is to have less people in hospital. I don't think that's anyone's goal, that we want to, you know, fill up our psychiatric units more and more and more. So while doing that work, you know, in these units and kind of expanding from there, but looking at the things that are working, that are making a change. Something that came out of PIPES was requesting to have more peer support there, and that's something we've been able to do. And recognizing too, going back to that relationships, is first and foremost being there to listen to people, and recognizing, as Clara was saying, the amount of staff that are so busy, and even if you wanted to sit down and listen to someone's story for an hour, they just don't have the capacity to do that, and that is what we're there for. And from that non-clinical perspective, and even having people in a place like that to help, what's the word I'm looking for? De-escalate. In a really challenging environment, I think has a lot of effects in different areas. So I would like to see more people with roles like myself. I don't know anybody else that has my job title, and I think when we have those unique positions, and like Clara's, who's able to keep that ball rolling, that's how it continues to move forward. It's like that snowball going down a hill. But the more snow that you can add to that, the bigger it's gonna get. I don't know if that makes any sense, but that's what came out of my mouth, so I'm gonna leave it there.
Thank you for that, Zoe.
to
That was
add?
great.
Maybe just add briefly that I think, like as much as I always want to advocate for bigger changes on a bigger level, and I think we could all agree, like more healthcare professionals, bigger hospitals, more beds, all those things. I think these projects have really focused my attention on what is possible through relatively small changes. And I think spreading the word that those small changes can really make a huge difference to morale, to patient experience. I think we hear again and again these small things that make a difference. And the example that many in this room have heard me speak about before is these self-care items in our Psych Emerge. So it came from staff, it came from patients and families saying, people are often in crisis when they come into Psych Emerge. They may not have basic self-care items with them, you know, deodorant, shampoo, conditioner, things like that, and it makes a huge difference to be able to look after yourself. It makes a difference to your mental health, to your feeling of wellness, and so we were able to provide some of these through a donation from Soap for Hope, which is a great organization that does repackaging of supplies from hotels and resorts, and we circulated them to all of our mental health units. And shortly after doing this, we had a staff member come up to me and she said, just being able to give someone a deodorant to take home with them, to use on the unit and then take home with them, she said the patient asked her, can I keep this? And she said, yeah, it's yours to take home, like it's for you. And she said the patient shared with her how meaningful that was for them just to be looked after. And she said, as a healthcare worker, I feel like I get to nurse somebody the way I did, 6 years ago, pre-pandemic. It's been so many years since I got to feel like I genuinely were looking after people like a human being, and it just was a level of hospitality. It was a $2 intervention, and it made all the difference in the world. So I think sometimes focusing on those bigger picture things can detract from how relatively easy it is to impact a patient's experience in the hospital, or family members or staff members. So I would say both, yeah.
Great, thank you. Dr. Reed was talking about how the local level was so important as well. That just speaks to that. Okay, we'll go to the microphone on this side.
Hi there. I'm a member of PIPE, so I'll just give you that secret. One of the pieces I wanted to bring forward was PIPES as a mechanism. When we're talking about people with lived experience being at the decision-making table, you get quite invested. Excuse me, become quite invested in that decision-making process. And the PIPES model allows for the people who were part of the research, part of the decision-making process, to then still be at the table after to make sure that these things continue, especially in the realm of a high clinical turnover in terms of people working there, who's remembering the changes, who's implementing them. Could you speak a little bit to how you are managing the monitoring of the improvements and how we address that at the PIPES meeting?
Sure, yeah, I think it's a great point, and I really appreciate, so like Jennifer says, she's been engaging with us since 2021, and so she's been one of our longer standing members of the team, and I think you've seen many changes even in the way that we've engaged over that time. So I think part of it is having that institutional memory and trying to preserve people's energy for this work so that those brains are at the table. The way that we've been monitoring it on a larger level is tracking the intersection between what comes up in these PIPES meetings, what comes up in these quality improvement huddles, the way that those are often speaking to the same key priorities in terms of how to improve patient care, supplies, communication with caregivers at these often kind of fraught moments of handover between the emergency room, Psych Emerge, discharge, and sort of trying to represent them as common goals, and then assign, as these topics come up, as these projects come up, assign them to those, provide updates in the PIPES meeting and in the huddles, so filter them back down again, and so that we don't lose sight of I think, number one, the priority, and number two, the fact that we're hearing from both seemingly maybe oppositional or interest holder groups from other sides of the spectrum, the patients and the caregivers and the staff and the clinicians, are really speaking with the same voice about what's needed.
Perfect, thank you. Okay, and it's Pat, right?
Yes.
All right.
I'm part of a nutritional committee at Providence Health, And some of the patients there were going home after long-term stays more malnourished than when they arrived. So they knew that they had to do something different. So what they did, they introduced a dietitian's aide on one of the wards. And what they found was it had great success. Patient outcomes were far better with nutritional status being monitored and improved. And one of the things about the science out there, new health research, it says it's never too late for nutritional benefit. You can have comorbidities going on, and when the patients are on intravenous IVs, when it's changed from plant-based IVs or from dairy-based IVs, which is the norm, to plant-based IVs, they do better. Just a 3% change in one's diet from animal products to plant products has measurable benefits. So, you know, it's never too late to see benefits through nutrition, including in a long-term care setting. Thank you.
Thank you for that.
I can add something because I'm working in long-term care, nutrition. So as you know, when we are aging, we have 5 genetic problems: dementia, delirium, and depression, and also incontinence. And at the last time, it is slowly patient goes to palliative care. So what I observed that in the long-term care, they are giving their own dietitian is already there, and they're coming and asking how is the food. And sometimes I am also feeding, and I see somebody cannot eat the food, and so we have to struggle feeding them, but we try our best to feed them. And every week, I think they are doing their weight measurement, and in this way, we meet the requirement. And this is going on.
Thank you for that. Okay, I'll go with the microphone on this side, and that's probably going to be the last question because we're close to lunch. But you can put it in the app, and we can see if we can
Sorry,
get
Delia. My name is Magdalena Newman. I'm with Fraser Health and the BC Support Unit. I have a question for Janice. For me, it seems like long-term care is a nice fit for micro-research, and I could see how, that could really be kind of stood up, right? And different micro-research teams happening within long-term care. I wonder if you could maybe talk a little bit about how micro-research could be adopted in other programs, other clinical programs, and how it could work within, say, mental health substance use or, what have you, maternity care, anything.
Well, I guess from what I've learned from our colleagues that created the micro-research approach, they've used it in many different areas and within many different communities. One of the key criteria they have is they don't go anywhere where they're not invited. So I think what it takes is that, that drive and interest to want to engage within community-based research and to have that research process within your own hands and that. But I'd say as long as that drive is there, I've found that the Micro-Research Canada has been very supportive and helpful within that process.
Thank you for that. That's a great answer. Okay, so I think we have 5 seconds left. I've run us a little behind, but we're right before lunch, so I think we're going to end our session here. Thank you to everyone for your participation, all our presenters. I think to me these sessions have really represented how learning health systems are a key component of care and where we're going to continue to see innovation and growth in the future in healthcare. So thank you for that. I'm just doing a promo for the posters at the moment. The posters are open, and we have so lunch starts at 12:45, so you have about 15 minutes between sessions, so if you want to mingle over there, there's some really amazing work over there. And other than that, thank you for joining us today, and have a great lunch.